welcome to your first online lecture for Oral Path. Now, I'm not going to list every objective for chapters 1 and 2 because the list is pretty long, but you can find our objectives in your syllabus addendum and or on Canvas. Now, when you're studying for your exams in this course, you're really going to want to make sure you have a good grasp of all the objectives listed under each chapter. Now, some of the terms we're going to talk about you may already have familiarity with, hopefully, but you're really going to want to have a deep grasp of the definitions and examples so you can have a good foundation moving forward in the course. The first thing I want to do is talk about some of the terms and give you some examples. Some of these examples are from the book, but most of them are outside examples because I want to add to your depth of knowledge. So you can study the pictures that you see in the book, you can see different examples in our online lecture, and then we're going to do some activities in class to try to help bring it all together. I do want to say I apologize for the sound quality in this video. It is not where I would like it to be because I have a special microphone for recording that is not working right now. I'm hoping to have that fixed by the time we have our next online lecture. If you haven't already downloaded and printed the handout that comes along with this lecture, you're really going to want to do that. You can pause the video at any time in order to write down information that you need. And the beauty of having the online lecture is you get to watch this lecture as many times as you want to. Now, the first thing we're going to talk about are some definitions regarding appearance. These are some of the descriptive terms that you're going to want to know regarding how to describe the appearance of a lesion. The first one I want to talk about is a bulla, or also called a bullous. So this is going to be an elevated lesion that is well defined. It's going to be larger than 5 millimeters in diameter, and it's going to contain serous fluid. To simplify this, it's going to have the appearance of a blister. Another example would be a sunburn. So here in this picture, we see someone who's had a really bad sunburn and it's blistered up. And here in the middle, you can see there's a very large bulla that has developed. So with these types of lesions, the fluid will eventually escape. Either the bulla will pop and the fluid will escape, or it will just deflate during the healing process. Another example would be impetigo. So you can see this person has a very serious infection of the skin, which has developed a bulla in one of the more severe areas. So bulla can develop from different reasons, and one of the most common would be some type of burn. The second one we're going to talk about is lobule. This is going to be a smaller segment of a larger lesion. Sometimes those segments are fused together. So in this picture, we see a very large palatal torus that has multiple lobules. So here you see a lobule of a larger torus, and then all these lobules are kind of fused together to create the bigger tora. The next one we're going to talk about is a macule. A macule is a flat, non-elevated, usually distinguished by color from its surrounding area. A good example would be a freckle. And here we have a patient with a freckle on their lip. So this is a hyperpigmented area of the skin. When we describe something as a macule, that should signal to you that it is probably not a serious thing. It's flat, so it's not cratered, it's not raised. It usually is very distinguishable from its surrounding area, but otherwise it is not a threat. A papule is a smaller circumscribed lesion. It's going to be less than 1 centimeter. So here we have a patient with a papule. It looks like a raised mole, and it is elevated. So a papule can get quite large because 1 centimeter is pretty large. This lesion looks to be a few millimeters in length and width. A pedunculated lesion, when we talk about pedunculated and sessile, those two terms are describing the base of a lesion. So with a pedunculated lesion, this is going to be attached by a stem-like or stalk-like base. It's going to have the appearance of a mushroom. So you can see here this lesion is larger than its base. So the base is smaller and stem-like, and this has the appearance of a mushroom. Therefore, we would call it a pedunculated base. A pustule, these are going to vary in size, but a pustule is going to be something that contains pus. So here we have a pustule intraorally in what we would suspect would be some type of abscess, would be my short list. And here's another example of a pustule. This is an acne lesion. So as we're in dental hygiene school and we get super stressed out and we all start to get those pustules on our face, these would be just acne lesions. So a pustule is a lesion that contains pus. Now here is an example of a sessile base. So here you can see that the base of this lesion is similar in size to the lesion itself. Therefore, the base is sessile versus pedunculated, where the base was more stem-like or stalk-like. And the last one we're going to talk about regarding appearance is going to be a vesicle. A vesicle is going to be small elevated lesions less than 1 centimeter in diameter that contain serous fluid. So vesicles are often seen in groups versus a bulla, which is going to be one larger fluid-filled lesion. A vesicle is going to be in a cluster of lesions, such as in HSV2. So this patient has an outbreak of herpes on the vermilion border of the lip there, and you can see that there are multiple lesions, so they have a vesicle, multiple vesicles that have formed there. Okay guys, let's talk about consistency. The first thing we want to talk about is a nodule. So a nodule is going to be a palpable solid lesion up to 1 centimeter in diameter that is found in soft tissue. For example, a lymph nodule. So here we can see that this patient has an enlarged lymph node, so we would consider that a nodule. Here's another example of an enlarged lymph node. Now, I want to point out the obvious here. This is a nodule which is much larger than 1 centimeter. So I don't necessarily agree with the textbook size description on this one. But for testing purposes, if there's a question about nodule size, just select 1 centimeter. Now, along with consistency comes the word palpation. Palpation is the term used to describe a lesion when you're feeling it with your fingers, so it's palpable. Now, when describing palpation, we can use terms such as soft, firm, semi-firm, and fluid-filled. Some of these terms overlap the description of appearance.
Hi, Nate. Hi. And Nate is my precious little boy, and he's going to help me in demonstration of palpation. I know you guys remember we learned about how to palpate. I know we talked about it in oral anatomy, and I know that you learned that in Miss Norell's class as well. When we are palpating the lymph nodes, we are trying to feel if there are any nodules with our fingers. Sorry, those are my little fur babies. And so if I feel a nodule, then that would be a positive sign for lymphadenopathy. And then at that point, I would be able to describe that nodule as soft or firm, mobile or non-mobile. And the idea behind palpation is that we would not feel anything. So if I feel something, then that's going to be a positive sign of something that we need to research further. So thank you, Nate. Say bye.
Bye.
Now, when describing a lesion in terms of color, color is of particular interest because the color of a lesion can give us clues as to the origin of that lesion. So some of the fundamental colors that we might use to describe a lesion would be red, pink, salmon, white, blue, black, gray, brown, or black. However, there are some more specific terms that you're going to want to know. So we're really going to hone in, focus on these 4 terms. The first one would be erythema. When you're in clinic, you're going to be responsible for identifying gingival erythema in your patients when you do your gingival descriptors. So this would be an abnormal redness of the mucosa or gingiva. You're going to probably use this term frequently because the majority of our patients will have erythema in at least one area of the mouth because of gingivitis. So here in this pic, you can see there's a clear distinction around the gingival margin of tissue that is much more red than the surrounding tissues. This would be a great example of gingival erythema. The next one would be erythroplakia. Erythroplakia is a term that means there is a lesion that appears as a smooth red patch or granular red tissue. It can have a velvety appearance. So here we have a picture of the lateral border of the tongue, which has a very obvious erythroplakia with a lesion in the center there that is protruding. So some type of, looks like some kind of nodule. This would be very concerning. So the 2 most common places, or I should say the 3 most common places for oral cancer would be the throat, the lateral border of the tongue, and the floor of the mouth. So when we see a lesion that presents as erythroplakia on the lateral border of the tongue, we should be very concerned about that. Leukoplakia is, here's another example of erythroplakia. This one is in the gingival tissue, so it might be difficult for the untrained eye to distinguish this from erythema. However, in the gingival tissue, if I saw this, I'd be very concerned because the redness extends beyond the gingival margin. And there is a well-defined border to this erythroplakia. So I'd be pretty concerned about this, and I would think maybe there's something more going on here than just gingival erythema. Now, leukoplakia is going to be a white plaque-like lesion, except the plaque-like substance cannot be rubbed off. So here we have an example of a tobacco chewer's leukoplakia. So this is in the vestibule, the lower mandibular vestibule, where this particular patient is holding his tobacco. And so it has developed a leukoplakia. And if you were to wipe that, it would not come off. You're going to see this very frequently because just about every patient who uses tobacco in snuff or dip tobacco is going to have a leukoplakia develop. Leukoplakia is, I guess, if you were considering the severity of a lesion, I would be less concerned about a leukoplakia than I would an erythroplakia. Now here is a very interesting lesion. Remember I said the 3 places that you're going to see oral cancer the most often are in the throat, the sides of the tongue, the lateral border of the tongue, and the floor of the mouth. So here we have a mixed erythroplakia and leukoplakia. So erythroplakia and leukoplakia are precursors to oral cancer. These are lesions that we really want to evaluate thoroughly. So I'm going to zoom in on this because I want to make sure you can see the difference between normal leukoplakia and erythroplakia. Here we have a normal appearance of tissue. This is the normal tissue of the tongue and normal tissue of the floor of the mouth. And then we can start to see very clearly that there's a white appearance or a leukoplakia starting. And then that leads us into an area of erythroplakia. So we have a mixed erythroplakia leukoplakia. This is a lesion that I would be highly suspicious of carcinoma because the mixture of erythroplakia and leukoplakia on the lateral border of the tongue is not a good sign. Okay, and the fourth descriptor that I'm going to really focus on here is pallor. So pallor would be a very pale color to the skin. People may have pallor when they're about to pass out, for instance. So in this picture, we can see that there's a very gray ashen appearance to the tissues, but there's very little color in the lips. So pallor can be a descriptor for the oral cavity as well. In this picture, we can see that the gingiva is lacking color, but is it really pallor? I'm really not convinced, guys. We're comparing the gingiva to its surrounding tissues here, which appear to be very red in this photo. If the lips were pale as well, then I would say it was probably a true case of gingival pallor, but I can also see that the mucosa and the tongue have plenty of color as well. So I'm really not convinced that this is a true case of gingival pallor. When describing a lesion, we always want to record the size of that lesion. Typically, we measure lesions in increments of millimeters because we use our probe to do the measurement. So here you can see they are measuring this fibroma with a probe, and it appears to be about 4 millimeters in length, and then they'll measure the width. And so they'll say a circular, well-circumscribed sessile fibroma with a sessile base. There are times when lesions grow so large, however, that we need to use centimeter measurements in our description, but usually we can get those descriptions with our probe. The texture of a lesion can also give us clues of its origin, so it's important to use medical terminology when writing our notes and speaking with each other in regard to lesions. A corrugated lesion, for instance, tells me that this is very wrinkled in appearance. We see this a lot with tobacco chewers' leukoplakia, so you've already heard me talk about tobacco chewers' lesions. This is something that I want to make sure you understand because you're going to see this much more frequently than people in the rest of the country. We have a very high rate of tobacco chewing in East Texas. Here we have a lesion that is extremely corrugated. It contains leukoplakia and erythroplakia. So I would be very concerned about this lesion. This is a pretty extreme example. Usually it's not this severe, but unfortunately I have seen several of these with a mixed erythroplakia, leukoplakia over the years. And in this case, we would go ahead and refer the patient out. Otherwise, if the patient has a leukoplakia that's corrugated that we're concerned about, we would bring the patient back in 2 weeks. And if the lesion is still there or unchanged, then we may refer the patient. In the meantime, we would ask the patient, between those 2 weeks, we would say, hey, let me show you this. This looks very wrinkly and we're very concerned about it. So if you're not ready to quit, then let's have you put that tobacco on the other side of your mouth and see if we can't get this to heal up. It's very interesting how quickly the body heals, particularly in the oral cavity. And if they move their tobacco to the other side, in 2 weeks' time, you will see tremendous improvement. And if you don't, then we would want to go ahead and refer them. A fissure is the meaning of a deep cleft or groove in a tooth, like a deep fissure on a tooth. This would be considered normal on a tooth, but it might clue us into the need for sealants in this patient. This is a great picture of a before and after sealant placement, so you can see how the sealants help protect that fissure from strep mutans, which is the bacteria that causes decay. A papillary lesion is going to be a small clustered like projection. So it's going to look like a wart. So it has a wart-like projection in the mouth. This is a lesion that we would refer to the oral surgeon. Sometimes these are the result of a HPV virus, a human papillomavirus, but unless we get that under microscopy, we really don't know. Other words that we may use to describe a lesion would be smooth, rough, and folded. And those are just terms that you may see in your practice. Radiographic terms. Now, you've learned a lot of this last semester, so hopefully some of it is a review, but I do want to go through this in a bit of detail so that you can really have a good understanding pathologically what you're looking at. I know you learned some of these words descriptively when interpreting radiographs, and now I want you to think of it in a pathological term. The first one would be coalescence. This is going to be a fusing together or growing together. We might use this term when the edges of a lesion have grown together with other structures that make it difficult to define the border. In this picture, it's difficult to determine the exact border of this lesion because the lesion has coalesced with the surrounding tissues. So it's really just destroying everything in its path. Diffuse, this is a lesion that is again difficult to define because the borders are broad or impossible to distinguish. Diffuse lesions are usually not a good thing, so this lesion would be a good example. We would see in a patient like this, immediate referral. I'd probably be on the phone with the oral surgeon's office trying to get them in that day. And they would probably have some swelling extraorally. This is a very, very large lesion. You should be able to feel it on the mandibular border of the jaw as well. Multilocular. Here is an example of a multilocular lesion. This is actually an odontogenic keratocyst. You don't really need to know that right now. What you need to be able to recognize is that soap bubble appearance with this multilocular lesion. So if you look closely at the lower right, think about when you were a kid and you were blowing bubbles and you would blow a huge bubble that had like multiple bubbles attached to it. That's what a multilocular lesion is. It's a bunch of bubbles all connected together. A radiolucent and radiopaque, I'm not going to go into detail. I know that Ms. Metlin pounded those two words into you, so we're not going to review those. If you need to review radiolucent and radiopaque, please do so. The next thing would be root resorption. Now, we learned about this in oral anatomy. We can have either internal or external resorption of the roots. In this pic, we can see that there is external resorption. Any guess what has caused this? If you don't know, you're going to want to look this up because it's part of your submission for this week. So in order to get credit for watching this lecture, you're going to have to make a submission. Your first question is, what is the cause of the external resorption seen in this radiograph? Other thing of mention here would be the internal resorption. So here is an example of internal resorption, which is very easily identifiable on the radiograph. Scalloping around the tooth. So this is a lesion that begins at the apex or in the alveolar bone and appears to travel up the PDL. This is a really good picture depicting the scalloping around the roots. Unilocular, as opposed to multilocular, this is an individual lesion with very well-defined borders where you can see exactly where the margins are. Think of this as blowing an individual bubble instead of a big multilocular one. Well circumscribed is another lesion that has a very well-defined border. So this is something kind of similar to unilocular. This is a very large unilocular lesion, but here we have a unilocular, well circumscribed lesion. Now, there are 8 categories that contribute to the diagnostic process. I'm going to discuss all 8 and give you some examples of each, so you want to pay attention and follow along with your handout so you can fill in your blanks here. The first one is going to be clinical diagnosis. When we're looking at pathology, we want to look at it from multiple angles. Clinical diagnosis is what we can see or palpate in the oral cavity that sometimes brings us to a diagnostic conclusion. Now, I know in this lecture I've used the word diagnosis and diagnostic a lot, and as hygienists we cannot diagnose, but we do help the dentist in preliminary diagnosis, and you are responsible for knowing all of these lesions in descriptive terms. When you are documenting, it's very important that you document these lesions appropriately, that you spell them correctly, that you understand what that dentist is talking about, but also to be a second set of eyes for the dentist. We have to work together in a team. If we can diagnose a lesion clinically, then additional steps like surgery can be avoided. Many of the lesions that we see in the oral cavity can be identified based on clinical appearance alone. So they're considered variants of normal. I'll give you some examples, variants of normal. The first one is going to be Fordyce granules or Fordyce spots. We can see that there are diffuse papules lining the buccal mucosa, so to an untrained eye, they might appear worrisome. But we know from our anatomy that these are just prominent sebaceous glands. Another variant of normal would be palatal torus. Palatal torus is just an excess growth of bone, but obviously if a patient were to look in their mouth and see this, they could be very, very concerned. But we can reassure them this is just a variant of normal. It looks concerning, but it's just a variant of normal. Melanin pigmentation. This is going to be an extra production of melanocytes lining the oral mucosa there. We also see that in the gingiva frequently. It's just a variation of normal. Lingual varicosities. We learned about this in oral anatomy as well. These are varicose veins that we see as people are aging. Fissured tongue. Geographic tongue. Now this one can really seem scary to an untrained eye because it has the appearance of erythroplakia, but it's not truly erythroplakia. If we look carefully, there is a loss of filiform papillae, which leaves a smooth appearance to the tongue, and that smoothness, when compared to the area around it, makes it appear that there's erythroplakia, but we know as professionals this is just a benign migratory glossitis. Median rhomboid glossitis, again, we have a loss of the filiform papillae, and this is associated with fungal infection. How can we forget about hairy tongue? Hairy tongue is an excess buildup of plaque and stain and filiform papilla because they're not shedding appropriately, usually as a result of poor oral hygiene. This is one you may not have been exposed to yet. This is an amalgam tattoo. An amalgam tattoo occurs when the dental amalgam leaks into the soft tissues. It could easily be mistaken for something really bad like a melanoma, but if you see that the patient has an amalgam filling directly above the lesion, you can safely assume it's just an amalgam tattoo. So that blue-black appearance of the gingiva. Usually let's look around and ask for some history and try to determine if it's an amalgam tattoo. And then the other one would be herpetic lesions. I don't like that the book says this is a variant of normal. This is a disease process, but I understand what they were trying to say. This is not something that we would refer or really get concerned about, except for the fact that if a patient has an oozing herpetic lesion, we do not want to see them. clinically. We want to wait until it's crusted over. If it's oozing, then we can spread that infection to other areas on that patient. And obviously there's a risk of infection cross-contamination for us as the provider, but our main concern is if we cross-contaminate that virus into other areas of that patient, it can cause a very serious herpetic outbreak in that patient that could end up with them hospitalized or even worse. So if the lesion is oozing, we're not going to see them in the clinic. We can identify this though pretty easily because the vesicles tend to come out along the same nerve path. Most of the time these patients have had these lesions in the past, so they're used to them and they have a history that we can ask them about and inquire about. Okay, we're going to stop because we're going to go back through these conditions one more time. Do you think that I want you to know these conditions? Yes. Are you going to have to identify these conditions again? Absolutely. Let's go over them one more time. Okay, again, we have Fordyce spots or Fordyce granules. We have a palatal torus, melanin pigmentation, lingual varicosities, fissured tongue, geographic tongue, median rhomboid glossitis, hairy tongue, in this case black hairy tongue, amalgam tattoo, and herpetic lesion. Now, radiographic diagnosis will also sometimes give us sufficient information in order to avoid surgical intervention. The first example would be a periapical pathosis, also called an abscess. Here we can see that there is widening of the PDL at the apex of the mesial root of number 31. Number 30. And that would probably have some accompanying pain, except for the fact that this tooth has had a root canal. So sometimes these lesions are only found when we take x-rays. Again, we have internal and external resorption. Heavy interproximal calculus. When you are in clinic and you're doing calculus detection, we're going to ask that you have your radiographs pulled up. Now, I'm not talking about your initial screening. I'm talking about if you're going for a calculus detection competency, we're going to ask that you pull up your radiographs because they're tremendously helpful when identifying subgingival calculus. We have to remember that x-rays are two-dimensional and teeth are three-dimensional. So just because I don't see it on x-ray doesn't mean it's not there. It's entirely likely for them to have calculus and me not see it on x-ray. And sometimes I see it on x-ray and I assume that it's heavy, but it's really just the angulation of the beam and the way that it's picking up that calculus. So don't assume just because you see it on an x-ray, do not assume it's heavy. It gives us a clue that there's calculus there, but that doesn't always mean that you can tell the density or size of that deposit. Carious lesions, interproximal carious lesions, are easily identified on radiographs. I can't tell you how many times I've seen a patient who looked absolutely fine clinically. There were no signs of decay, there was no pain, and then we take x-rays and we find a very large carious lesion like the one seen here. This lesion is large enough, it's very close to the pulp chamber, that if something's not done about it very soon, then this patient is going to end up needing a root canal or losing the tooth. The next one would be supernumerary tooth, along with impacted teeth. This radiograph in particular has a very specific type of supernumerary tooth. And guess what? That's right. This is your second question for your lecture submission. What is the most specific name of the supernumerary tooth seen in this radiograph? And the last thing I want to emphasize with radiographs is the identification of impacted or unerupted teeth. Now, please hear me. You guys need to use your pano when charting your mixed dentition. If you don't have your pano pulled up for reference, you're not likely to pass that mixed dentition charting. The pano is one of the best diagnostic tools when charting mixed dentition. It's better than your knowledge of eruption. It's better than clinical recognition. Please use your pano, please. Okay, next we're going to talk about historical diagnosis. So sometimes clinical appearance alone is not enough to diagnose a lesion, but if we question the patient about the historical context, we can gather enough information along with what we've seen to render a diagnosis. We may need to ask them about their family history, their personal history, their medical history, use of medications, how long a lesion has been present if the patient is aware. Now, we update our medical dental history at each appointment because all of that information gathered from that document can contribute to oral conditions, including pathology. If you're not sure why we ask something on that medical history, every single thing we ask has some kind of oral implication. So use that as a learning process. Why do we ask this? Don't be ashamed to ask those questions in clinic. That's why we are here. An example might be a patient with a history of ulcerative colitis or Crohn's disease may present with chronic multiple ulcers in the mouth. Or a patient with gingival enlargement, they may be misdiagnosed with gingivitis when in fact they're taking a calcium channel blocker or a phenytoin, which is known to cause gingival enlargement. This is gingival enlargement that is unrelated to periodontal pathogen. So if your patient's taking a calcium channel blocker or an anti-seizure medication and they present with gingival enlargement, then we have to do a little bit more digging to figure out, is this a pathogenic process or is this a result of medication? Go back there. Laboratory diagnosis. When we aren't able to render a diagnosis through clinical, radiographic, or historical means, then we have to refer that patient for more evaluation. Sometimes that's going to involve a medical doctor, sometimes an oral surgeon or a periodontist, but they're able to do additional tests that we can't do in a general practice that will help determine the cause of a condition. For example, one disease that I want you to know about is Paget's disease. This is a bone disease which will give a distinctive radiographic appearance that includes a cotton wool effect. Laboratory testing will be able to help in the diagnosis of Paget's disease. If we see this cotton wool appearance on a radiograph, then we need to refer that patient for laboratory testing. So please remember, this is a board alert. Paget's disease is likened to the cotton wool effect that we see on the radiograph. So those two words should go together or trigger something in you if you see that question. Now, a microscopic diagnosis can also aid in the diagnosis and it's considered a laboratory test. There's a great microscopic screening tool out there called a brush biopsy. We used to use this in our practice when I was in Jacksonville because we were so far out that our patients didn't want to drive into Tyler and go to the oral surgeon. But it's important to remember that these brush biopsies are just a screening mechanism and that scalpel biopsy is considered the gold standard. Scalpel biopsy is considered the gold standard. Please remember that. There were great benefits, though, to doing the brush biopsy. The results for a negative were very reassuring and accurate. The downside was that they could produce false positives. Now, all positive results that we got had to be referred to the oral surgeon. So another downside is that the test was painful. You really had to dig into these lesions in order to get a good sample. So literally the attempt was to make the patient bleed. And then you'd create a microscopic slide and send off the slide to an independent lab. I really enjoyed doing the slides for these. It was very fun and different, and it was a great benefit to our particular patient population. Now, a surgical diagnosis can be done when all those other things cannot identify a cause, but we want to avoid surgical intervention because it's risky and destructive. But it does provide a definitive diagnosis. That means that it is conclusive. It tells us exactly what that lesion is. We're not going to go into a lot of detail about surgical diagnosis, but just know that it is definitive. A therapeutic diagnosis is a diagnosis of exclusion. So we're treating a suspected disease process to see if an improvement occurs in the outcome. So for instance, a patient may present with thrush, which has a plaque-like film. This is not like leukoplakia because the white film can be wiped off. But underneath, you're going to find a very red and raw tissue appearance. So remember I said that erythroplakia should get your attention, but in this case, let's pretend the patient's taking an immunosuppressant and we highly suspect a fungal infection. We can prescribe a mouth rinse called nystatin, which is a potent antifungal, and have the patient return in 2 weeks. If that lesion is gone, then we've made a therapeutic diagnosis. If it's still there, then we would need to refer for further evaluation. So a therapeutic diagnosis means we treat what is most likely the cause, and if improvement occurs, then we diagnose based on our therapy. A differential diagnosis is a term that essentially means what disease processes do you suspect? So you're then going to try to exclude certain diagnoses based on your findings and narrow your focus to the most likely diagnosis. So here's an example. Let's say you have a patient that presents with a fistula, and based on clinical appearance alone, we can't reach a diagnostic conclusion. However, we would immediately have a very short list of differentials, which may include periapical abscess, periodontal abscess, or some other destructive type of unknown lesion. We can gather more information and ask the patient some pointed questions like, how long has this been here? Do you have any pain? Does it hurt with hot or cold things? And through our questioning, we learn that the patient noticed pain in his tooth when eating sweets, and that progressed into pain when drinking coffee, and now it throbs. And let's say he woke up a few days ago with a bump on his gums. Well, we can narrow our focus toward a periodontal abscess because the signs and symptoms really exclude a periodontal abscess. And it's really highly unlikely that the patient has an unknown pathosis. So our next step would be we would take a radiograph and we can see that the tooth has a large interproximal carious lesion and that there's widening of the PDL at the apex, and that's consistent with a periapical pathosis. So our differential diagnosis when we initially saw the patient was it could be a periodontal pathosis, it could be a periapical pathosis, it could be some unknown pathosis. But we were able to, through our other diagnostic processes, narrow that down and eventually reach a definitive diagnosis in this case. Okay, that's going to be it for Chapter 1 lecture. Now, if you have any questions after reading the chapter and watching the lecture video, please feel free to email me. We're going to do some activities in class to try to help bring this all together and solidify that in your memory. And I would really recommend that you take a break before starting Chapter 2. Otherwise, please make sure that you have gotten all of this information in your notes and that you study your notes in this lecture for your exam. And I will see you guys next time.